right, good. All right. Welcome, everybody. Go ahead and call this meeting of the Board of Health to order. It is August 13th. I show at about 5:05. So thanks, everyone, for being here today. Appreciate board staff for preparing a nice meal for us and welcoming us here in person. It's wonderful to see everybody's faces. We will go ahead and get started. We have the agenda in front of us. Are there any adjustments to the agenda that we need to entertain? All right, hearing none, we will go to the review of the minutes from the prior meeting. These were sent via email. Do we have any adjustments to the minutes? Or can I have a motion to accept the minutes as is?
Move for acceptance. As is.
We have a motion and a second. We will go ahead and have a vote.
We're in person, so you can say all the things.
We can say, all right. All in favor?
Aye.
All right, the ayes have it. Thank you very much. Gotta get back to this routine of being in person. All right, do we have any public comments? No public comments. All right, fantastic. Dr. Jenkins, we'll turn over to you for staff recognition.
Thank you so much, Chair Ray, and to the board. We just say good evening to you all and welcome back. Hope you all enjoyed your summer break, and it's good to have everyone in the room together. So we know we do have some other board members who are on the way, but this time I'd just like to take an opportunity to recognize a few staff members. On Monday, the Board of County Commissioners recognized 6 National Association of Counties, or NACO, Achievement Award winners for 2026. Those achievement awards recognizes innovation and outstanding county government programs and services. And this year's winner were honored at the NACO annual conference, which was held in Orleans Parish, New Orleans, Louisiana. It's important to note that throughout these United States, we have about 3,600 counties. So to be named or to be recognized is pretty epic. So Durham Public Health was recognized twice. We were recognized, and I just asked these folks to stand and be recognized for this great award. There was a vaccine anti-misinformation campaign. I'd asked Dr. Alicia Smith to stand and be recognized. Dr. Smith is our one-woman army when it comes to social media and our public relations. She serves as our communications and public relations manager. She does a wonderful job. So she was recognized. And then, of course, combating food insecurity in Durham, North Carolina. The Durham's Food Security Network. That was a partnership with Durham County Department of Public Health and Durham Cooperative Extension. Definitely like members of our nutrition division to stand and be recognized. It goes without saying that they do a whole lot for food security, but you also see inside the health director's report that they've had a lot of work going on with ending hunger in Durham. So again, it feels good to be recognized when our work is not done. But Mr. Chair, this great board, those are all I have.
Fantastic, fantastic job, everybody. Thank you. All right. Next on the agenda, we have 3 different administrative reports. So we will go ahead and move on to the first agenda item, which is our FY25-26 Quarter 4 fiscal overview. Ms. Gwendon, we will turn over to you.
Without our IT team. But, thank you all so much. So happy to see you in person. Always grateful for the opportunity to share with you about our fiscal health. Tonight I'm talking about Quarter 4 of the fiscal year that we just finished, and you all know the drill. First, a word about our budget parameters for fiscal year 25-26. We started that year with a budget of $28,410,835. We moved $1,301,649 into the budget throughout the fiscal year through budget amendments and rollover amounts. So the current, or the ending year budget, not so current, since we're in a new fiscal year, was $29,712,484. Our expense budget was $41 million, and that was a 4% increase from where we started the year. We spent about $35.37 million, or 86% of our general fund expense budget as of Q4. Most of the remaining funds were in lapsed salary, which is pretty typical. Our personnel costs totaled $23,805,159. Contract spending was $8,614,283. Some specific purchases from Q4 were $28,863 on Nexplanon implants, which is a form of birth control, $13,398 on breast pumps for expecting parents, $77,650 on collection kits and swabs to detect chlamydia and gonorrhea, and $20,926 on various vaccines. The department, at the time of this presentation that I made last week, the number is larger now, but we had brought in $8.64 million in revenue, which made up about 76% of our revenue budget. We are able to book revenue back into last fiscal year through the end of August, so this number is growing actually by the day. There is a significant, I've been telling you kind of all year long that we had a delay in our Medicaid cost settlement dollars, and I'm very happy to say that since I made this slide, those funds came in just in time for us to put them back into last fiscal year, so that will make my books look nice, which makes me happy. But that amount of Medicaid cost settlement dollars that came in that's not shown here was $1,435,507. So if we add that 1.4 to this 8.6, we get close to 10 million, or 88% of our budget. The other outstanding kind of large amount that we're still waiting on is 1/4 of our Medicaid quarterly directed payments. So this slide also illustrates that Medicaid lag that I was mentioning. Our grant revenues total $4,332,075, and Medicaid is $3,635,170. So as per usual, those two revenue sources make up 92% of our department's overall revenue. Our service fees total $675,500, and that includes patients self-paying as well as environmental health makes up a large part of that as well, our fees for environmental health. That amount is $25,000 higher than we were at the same point last year, so that's an exciting increase for us. And like last year, I also wanted to show you all at the end of the fiscal year how much of our state grants, or our AAs, or agreement addendum, as we call them, for fiscal year 26. So we were awarded 28 one-year grants from the state in fiscal year 26. These are funds that would be, if they were not pulled down, would be lost. They can't roll over into subsequent years. And they're also reimbursement based, so if we don't spend the funds, then we're not able to pull those funds. So of those 28 grants, which totaled $4.1 million, we collected $3.9 million in revenue, or 95% of those awards. Last year, that number was 92%. The year prior, it was 90%, and the year prior to that was 70%. So we're very excited about this upward trajectory. Of the $191,000 that we did not spend, a number of those chunks were associated with some things that you all heard about over the year, including stop work orders on particular amounts that we had throughout the year, as well as we had one small pot that is to be used for a state system specifically, and the state isn't ready to roll that out, so they gave us the money, but then we couldn't spend it. So in other words, things that were out of our control. So with that being the case, I'm very, very happy and can thank most of the folks in the back, as well as my fiscal staff and our contract staff for working so hard on pulling down these funds. And as you all know, our department was granted last year $968,000 of the county's opioid settlement dollars for last fiscal year for our 3 projects that were based in the health department: community linkages to care, harm reduction, and then the administration of the opioid activities. So at the year's end, we spent 84% of the budgeted expenses for last fiscal year. So, thank you all. That's what I have. Happy to take any questions, of course, and excited to move to. It's always fun to start the slate over new and start a new fiscal year. Yes, ma'am.
I'm just curious, you said that we collected more in self-pay. Do we know whether that's because more people are uninsured and we're now having to do self-pay, or whether it is fees from environmental health kind of thing, which would be sort of steady over the years?
Yeah, I think it's a combination of 2 things. We did have some environmental health fees increase for last year. I think, if I recall, there was maybe, 6 fees that for the prior year, so that's going to be a little bit of it. Another thing that we did was some of our immunization fees that were on a sliding fee scale, we kept them at a flat fee, which was just the acquisition price. So the COVID vaccine, for example, which previously we were sliding, we made the choice to do what many health departments in North Carolina do, and have a handful of vaccines that don't slide on that sliding fee scale. So that has a lot to do with it as well.
Thank you, Finance
Sure.
Commissioner, for this one, and as always, it might have been slide 3, but what's in the non-applicable bucket again? What constitutes any? Or, yeah, I think you just had it 2 slides
That
ago.
one.
And one more.
Tell me what.
It might have been the one, the
One
next
before
one,
it?
the trending. Yeah.
Was it about the budget or about expenses?
Back expenses.
Okay.
Yeah, that one. I see that.
Oh, yeah,
N
okay.
slash A.
Interesting, good question. I'm gonna have to look at it.
Okay.
I'm not sure off the top of my head. Those categories come from our specific general ledger line items.
Uh-huh.
So if we have expenses that don't fit into one of those categories, my guess is that JP, who you all heard from in our population health team, he helped, well, by help, I mean he built this dashboard. And so I think probably, yeah, I didn't have much to do with it other than sharing my ideas. But I'm thinking that is something that didn't fit there and got bumped into the category. But I can look, I
Yeah,
can figure out what that was and let you know. Yeah.
Just another quick question. You mentioned on the expense variance lapsed salaries. Can you just explain what lapsed salaries are?
Sure, yeah. It's when we have, we start the year with the number of FTEs. I believe ours on the books is 247, something like that. And we budget for the whole year as if those positions are going to all be filled, which you all, hear our vacancy report, we tend to hover around 10%. So even though those funds are budgeted, we're not spending those funds if nobody's in the positions. So as time goes on, that money accumulates. And I know the county as a whole does take into consideration that lapsed salary as part of their kind of overall savings. But when we're looking just kind of at our departmental expenses, that ends up being, because salaries are such a large part, our personnel costs in general, that ends up being.
Okay, thank you.
Sure thing.
Any other questions? All right, thanks very much.
Sure.
All right, we will move on to our next agenda item. And it's a presentation regarding the North Carolina Local Health Department accreditation and Public Health Advisory Board accreditation. So, Ms. Talley and Ms. Morboy.
Good evening, everyone. Welcome back. My name is Rochelle Talley. I'm the QA coordinator for the health department, and I'm just going to talk to you a little bit about our accreditation process. Right now, we're in the middle of accreditation for both national accreditation as well as local accreditation. I'm lucky enough, it's all in 1 year this time. So I'm just going to give you a little highlight of each one and let you know kind of where we are. So first I'm going to talk about North Carolina local accreditation. And let's see. Wait, okay, so for North Carolina, as you know, it's mandated that we undergo accreditation every 4 years. We were last accredited in 2013. Our accreditation was May 19th. May 19th, 2023. We were first accredited in 2013, excuse me. But our last accreditation was in 2023. And so it's a 4-year process. So we're coming up on our 2027 accreditation. The goal for North Carolina accreditation, as you can see, is to assure and enhance quality of our public health and improve the health of our community and eliminate health disparities. Essentially, accreditation is a quality improvement initiative. It works to look at our performance and capacity as a health department, to see how we're strengthening our partnerships, both state and local, and identify areas where we can make system improvements. It also assures that we have a strong public health system in place. Accreditation for North Carolina basically just shows that we are meeting all of the requirements for a health department in North Carolina. So it's not really saying, oh, we're great, or we're not. It's just saying we've met these, and this is so we're doing okay. I will preface this to say that North Carolina has just changed the requirements, and as of June 30th, we are undergoing like a whole new set of accreditation. So we're following the accreditation process for the last few years. They've tried to update that process, make it a little easier, consolidate it a little bit, and so we're one of the first counties to actually undergo the new process, which will be interesting. So what it includes is the biggest thing is our health department self-assessment. And right now we are trying to get together all our documentation for that and provide that to a dashboard. Once that's put into the dashboard, the site visit team, which is multidisciplinary and is voluntary for people who are on that team, and they look at all our documentation and then make a site visit, and which will probably occur for us. Our documentation is due at the end of December 30th for North Carolina, and we'll probably have a site visit sometime in January or February. And then they actually write a report. The report goes to the accreditation board, and the accreditation board only meets periodically, and for us it's usually May. So that accreditation board looks at the report that comes from them and then decides if we are accredited or not. This is just a timeline that we've been going through. So we last had our site visit January 25th, 2023, and then that actually determines our accreditation years for how we provide the documentation. So we're into our 4th year, and as I said, we will be having our winter 2027 site visit coming up. We should get our notification at the end of August, our 90-day notification. December 30th is when we have to have all the evidence into the dashboard, and again, our site visit could be anywhere from January to April, but generally we usually have January or the beginning of February. So as I said earlier, they drafted a new accreditation document. And this document is now, they named it the Accreditation Interpretation Document, or AID. And it's no longer a draft, because as I said, it became the rule as of June 1st, 2026, and is applying to all ongoing accreditation site visits. It now has 45 activities, and it has 11 standards, and I'll talk about that a little bit more in a minute. And those standards are under the foundational capabilities, which really is something that we'll talk about underneath FAB, because FAB has established those capabilities, and North Carolina is trying to align itself a little more with FAB. This is the foundational capabilities that they put in place for North Carolina. You'll see in a few minutes when I talk about FAB that it's very similar. The foundational areas are pretty much the same, but under the foundational capabilities, North Carolina has expanded the organizational area, and it's because they kind of want to have us give them more information about that, whereas FAB doesn't, they still have some documentation there, but not as extensive as North Carolina does. So the changes with the new requirements were that we went from 147 to 45 activities, which seems like a lot. And the documentation went from 257 pieces of documentation to 103 documents. Essentially, looking at it, I found that they did get rid of some things, but they also kind of combined a lot of things under one. They've also changed how they just will decide whether we meet something. Before it was either we met it or we didn't meet it. And now we're going to get points for partially met, either fully met or not met at all. And this actually follows FAB. FAB also does this kind of requirement for deciding, whether you've met documentation. And then to decide whether we're accredited, we actually have to have 81 points with at least, across a whole 45 activities with at least 4 points under each of the standards. So basically we have to at least reach that to be accredited. In North Carolina, actually, you cannot be accredited, but usually they work with that health department and help them to make the changes that are needed to actually become accredited. And so as far as the board is concerned, these are some of the board and governance documentation that we're going to have to be providing. So you can see we have to show them that you've had orientation and training as a board member, that you have access to legal counsel and that you use legal counsel when you need it, that you review the health director's performance, that you're approving the annual public health budget, that you're updating and distributing to elected officials of community partners information, that you're evaluating our finances and funding and any needs or opportunities that we have, that you're assessing the rules and policies and needs for potential rules and policies, which actually you're going to be talking about today, and that you assess the impact of the state laws and rules on public health and make recommendations to the legislature for changes. So I've provided you with some accreditation resources. Their website is listed here, and you can go right to that website. It will give you some more information about local and the changes that they've made. They will also provide you with the AID document if you want to look at that in a little more detail. And it talks about the entire accreditation process. We've also provided you with our employee quick guide. We redid this quick guide. We started this quick guide before we had the 2013 accreditation because we wanted employees to have some information that they could have in their pocket, especially when the site visit came. If they needed some answers, they had a place to look for it. But it also provides them with a lot of information about the health department and just a handbook. And so we do try to keep that updated. I'll just stop here for a minute. Any questions about local accreditation?
I have a question.
Yes, ma'am.
Was there any change in the standards that you're gonna be, judged under around health disparities? Because of all the, anti-DEI stuff, I didn't know if it trickled down to this.
Yes, they did. I think they actually removed a few things, or altered a few things, because they had time to do that, because they really didn't, although they were working on this for a long time, the last version of this didn't come out until June, and it actually was approved by the board in June. So they had asked for input from everybody, plus they were looking at those types of things that they had to kind of remove. So there were a few things that they took out from what we had previously in accreditation.
Thank you.
It wasn't a lot, but it was just a few things. Not hearing anything else, I will continue. So then there's FAB. So FAB is national accreditation. And interestingly enough, FAB had a lot of information when they were established from North Carolina, because North Carolina, a lot of the individuals from North Carolina actually went to FAB when it was started. So a lot of that information actually went there. And so we had a lot of cross information between FAB and North Carolina. And that is another reason I think that North Carolina was trying more and more to align with FAB for us. And FAB, as you see, is the National Public Health Accreditation Board. So their mission is to advance and transform public health practice, championing performance improvement, strong infrastructure, and innovation. So again, it's an innovation, it's an improvement. They want us to advance what we're doing, and they use this to help us with that. And they want to have us as high-performing public health systems throughout the country. So they're still aligning the 10 domains with the 10 essential public health services, but also with those foundational services. North Carolina is, even though I didn't mention that earlier, I mean, we're still kind of aligned with the 10 essential services, and the first accreditation that we did was actually aligned directly with 10 essential services. But again, they've kind of moved to this foundational capabilities. So this is how the foundational capabilities are set up with FAB. And it's essentially the same. You do see equity in this, and you do not see equity in North Carolina at the moment. And even though they have equity here, they have removed a few things actually from documents that we have to require, that we're required to provide them. But again, as far as the overall organizational, how we're set up in that, they do have that in FAB as well, but not as expansive as you saw in the North Carolina local. So essentially, FAB still includes a health department self-assessment. Interestingly enough, FAB changed their assessment as of July 1st. However, because we began earlier, we are still under the 2022 version. And I tried to provide you with that document. However, they removed it from the website, so there's no way for me to actually do that. If you'd like a copy at some point, we can actually send it to you, that you can look at it. So again, right now our FAB documents, we're in the midst of putting them in the dashboard, reviewing them, and getting those done. Then there will be a site visit, again, with a multidisciplinary team, assessing the operations, and then from there they will determine whether we're accredited or not. Their reaccreditation occurs every 5 years. And one of the big differences between North Carolina and national is that in those 5 years, we still have to provide reports on a yearly basis to them, showing that we're still progressing with what we're doing. So it's a little bit, North Carolina hasn't told us we have to do that as of yet, but in FAB, we do have to provide them with updates. So with that, there are the 10 domains. And each of those has one or more standards with one or more measures that we have to provide. The requirements are specified under each of the measures. Again, one or more documents that we have to provide to them. And these are going to be due in the dashboard by September 10th. So we are right now really concentrating on FAB, because we're trying to get that all ready to go. We're about probably 60%, somewhere around there, Marissa, area, but it takes a while to actually get the documents together because they have to be provided to them in a certain manner. So it takes some time to do that. But we feel like we're in a good place and we're, working to get that all done by the 10th. And again, I provide you with the resources. They do have the website, and you can go to the website. You will see the new document on the website. And like I said, I couldn't provide you with the old one. There's some more fact sheets about the foundational services. Again, you can refer to our guidance document. There is some information in there as well about FAB. So for you, it's, some of these, the same things that were required for the board under local, some of them are also included, especially training, orientation, and things about our budget. Those are all included in FAB as well as the North Carolina accreditation. And do you have any questions? Yes, ma'am.
I just have a request. I may have missed it, but what was attached as the presentation was actually the FAB, I think, the full document. So I don't at least have your presentation, so I'm just wondering whether we can get that sent out.
We're happy to do that too.
Right, yes. Yeah, you get the present, the link should work, I would think, on the document.
I have the full document.
Oh, okay,
I can't remember if it's FAB or the local health, but I have an accreditation, it's like huge document, which I wasn't going to read.
Make sure you get it.
Yeah, thanks.
But we will do that, yes. I was trying to think of something, anything else that you would, the site visit, that was the other thing, is that as far as, with they come for the site visit, they do interviews. And generally, the chair is the person that's interviewed for North Carolina as well as for FAB. We'll get more information about that coming up. We haven't heard a lot from FAB yet about the site visit. We don't know how quickly that will happen once they look at our documents after September 10th. But they may be close. It could be November. But they have certain time periods actually when they do the site visit. Cross your fingers, it's not going to be the same time as local in January or February, but we'll probably coordinate that because we have a little bit of options as far as local accreditation. So we'll be finding more information on that.
To my question, I remember the last visit, that the site visit, that you, the chair, the vice chair, came and sat through an interview process. So happy to participate, obviously. Just keep us informed as to what it's going to be.
Oh, absolutely. And, they don't really provide us exactly. I don't know if FAB will provide us with more direct information, like what are they going to be looking for.
Yeah.
North Carolina, and when we first had accreditation, they did, and then they kind of took that all away, and they just, basically, I think they were pretty general in letting you provide the information to them generally about the health department. So, but we will provide that information to you as soon as we know.
Great.
Mr. Chair, members of the board, proud to say that I've been a site visitor for FAB since 2020. I've done probably like 3 or 4 different site visits to include military installations. And it mirrors that of North Carolina local health accreditation. So I can say with surety, Mr. Chair, you can expect for us to grill you, so to speak. And
Please do.
They're going to talk to community partners, they're going to talk to leadership, they're going to talk to county leadership as well. So we look forward to it. I'm one to envision success, and I feel that we will be successful in both endeavors. I just look forward to, I think right now it's Cabarrus Health Alliance, Burke County, the North Carolina Department of Public Health that's FAB accredited, and why not do it? So we look forward to successful attainment of FAB accreditation.
And we have an advantage in a sense because they based it on us.
Right.
We were almost like the first, state to do this. And, every state, if you look on their website for FAB, you can see, every state, how many places they have accredited. and reaccredited, so we can kind of get a big picture of like, you know, who is doing this. But I think for the other states, it's been more, because it's not required necessarily unless their legislatures are requiring them to do that.
Perhaps with the exception of Ohio. Ohio, Micah, they make it mandatory.
Okay.
Yeah, and we were kind of wondering whether they were going to move us into that direction as well, but as far as I know, not at this point, so.
So what, obviously that's voluntary. State of North Carolina accreditation is non-voluntary, right, or is it
Nah,
also?
it is mandatory
Mandatory.
because it's written in the general statute.
Right. So, just from a just general risk perspective, what is, while we're fully confident that we're getting accredited, if we fail or get, say, conditional accreditation, what would be the impact if that were to happen?
No real impact, to be honest. They, as Rochelle eloquently stated, both national and local will do everything within their power to assist you in getting that obtained. So they'll give you time, they'll give you opportunities to correct. So it's really a reward per se for putting forth the effort.
Thank you.
And we've done very well with local accreditation overall, I think. I mean, we actually, 2013, I think we actually were perfect, 2013. We missed like 2017, then it was extended because of COVID, so we didn't actually have it until 2023 again. So this is actually our fourth, and we were actually perfect the last time as well. But just to say, I mean, I hope we could be perfect. I don't know that, sure, just because of all the changes, and it's happened so quickly. And hopefully we can meet as much as possible. I think we will still pass. You know, we may have some things that we need to correct. I think that's the purpose, actually. So I don't think they're expecting that either, because they actually took away the honor system in local, because we did get honors in the last time, but they took that away until all the health departments actually complete this new process. So we will be asking, I think Chatham County is like one of the first group that's going through this. They will be going through it pretty soon, actually. I think they have to get their documentation in now. So we'll probably talk to them a little bit to see like how it went and things that maybe they can help us with. So
Phone a friend and see if they'll give you some pointers.
right, exactly. So
Awesome. Any other questions? Sally, thank you very much. Really appreciate it.
thank you very much.
All right, and for the last administrative report for the evening, Ms. Sturdivant and Llewellyn are going to present updating Durham County's Board of Health smoking rule.
Good evening. My name is Jasmine Sturdivant. I'm the Region 5 Tobacco Prevention Manager, and presenting with me is Emma Llewellyn. She is a health education intern, and she's pursuing her MPH at UNC Gilling School of Public Health with a concentration in health policy. So I'm going to let her start the presentation.
Hi everybody, thank you so much for having me and Jasmine here with you all tonight. So I'm just going to provide a brief overview of our presentation and our time with you all this evening. To start, I'm going to provide an overview of Durham County's Board of Health smoking rule, and this is from the time that it was created in 2012 and how it's been updated and our need for change now. And then I'll provide some tobacco use data specific to North Carolina to provide a little bit of context. And then we'll talk about what comprehensive smoke-free policy can look like here in Durham as well. And then I'll hand it back over to Jasmine for providing you all our proposed changes to the Durham County Board of Health smoking rule and then kind of the next steps. So like I said, we're going to start with an overview of the smoking rule. So in 2012, the Durham County Board of Health enacted the smoking rule with a very clear and intentional purpose of regulating smoking in public areas across the county. While the rule has undergone updates over time, at its core, it protects the safety, health, and overall well-being of Durham County residents. In 2012, the rule was considered to be very progressive, very comprehensive, but at the time it did not include the use of e-cigarettes. As we've learned more about the dangers of secondhand smoke, as well as e-cigarettes, the rule has evolved. So in 2018, the Board of Health expanded the smoking rule to include e-cigarettes, as well as it expanded the list of public places in which smoking was prohibited. And then I'll give you all just a moment, if you'd like, to scan the QR code on the screen to access the current Board of Health smoking rule, though it's also in your packets. While you all are doing that, I do just want to highlight that the evolution of the smoking rule definitely demonstrates the commitment that Durham has to staying up with public health information as we receive it. So, thank you. So now I will provide an overview of tobacco use in North Carolina. To understand why updates to the smoking rule remain so important, it's helpful to understand some of the trends in North Carolina data. Particularly e-cigarette use is especially prevalent right now. So North Carolina ranks 6th highest in the United States for youth vaping. Statewide, an estimated 12,500 middle school students currently report using e-cigarettes, and more than 1 in 5 high school students in North Carolina report the use of e-cigarettes, which is more than twice the national average of 10%. The increased use of e-cigarettes among North Carolina's youth is especially concerning and underscores the importance of continued action, both in strengthening protective policy as well as supporting community education efforts. E-cigarette use among adults is also quite high. In North Carolina, we rank 17th nationally. Looking at tobacco use beyond just e-cigarettes, though, for adults, the tobacco use rate in North Carolina is 21.6%, and these data points we feel also signal the need for continued action by this board. So looking towards where we would like to be, Healthy NC 2030 is a community engaged project that sets targets for various health indicators, including tobacco use. In North Carolina, the desired result is decreased tobacco use. The target among youth is 9% for those who report the current use of e-cigarettes, cigarettes, cigars, smokeless tobacco, pipes, and or hookah. And then among adults, that same target is 15%. As you can see from the last slide, we are not currently meeting those targets. So now I'm going to provide a brief overview of comprehensive smoke-free policy and how we feel that we can move closer to our target goals. To achieve the Healthy NC 2030 target for reducing tobacco use, it is essential that Durham County does its part by establishing comprehensive smoke-free policy. The CDC defines comprehensive smoke-free laws as those that prohibit smoking at all times in all indoor areas of workplaces, restaurants, and bars. If a law allows exemptions for designated smoking areas or designated and ventilated smoking areas in workplaces, restaurants, or bars, then it is not considered to be comprehensive. In just a moment, I will show a model policy that is aimed at reducing tobacco use. But first, I just want to talk through a few of the benefits of comprehensive smoke-free policy. First, it reduces secondhand smoke exposure. Evidence indicates that there is no safe level of secondhand smoke exposure, and comprehensive smoke-free policy works to protect those who are most vulnerable. Secondhand smoke is an independent risk factor for many things, including lung cancer, coronary heart disease, and stroke, as well as an increased risk for low birth weight babies, sudden infant death syndrome, and lower respiratory illness among children. Comprehensive smoke-free policy improves health outcomes by reducing exposure to secondhand smoke. Next, it's important to note that comprehensive smoke-free policy reduces smoking and encourages smokers to quit, as well as prevents smoking initiation by reducing the environmental and social cues that normalize smoking. This is especially important among youth. And finally, the last thing that we would like to highlight as a benefit is that in North Carolina, the annual direct healthcare costs associated with smoking total $3.81 billion, and the estimated annual costs associated with secondhand smoke are approximately $293 million. One way that we have decreased these costs is through North Carolina's smoke-free restaurants and bars law, which reduced the weekly average ER visits for heart attacks by 21%. Further, comprehensive smoke-free policy does not have adverse effects on businesses, and specifically, we think it's important to highlight that it does not have adverse effects on the hospitality industry. As I mentioned, I am returning to provide a model policy here. So this is a model tobacco-free policy from the North Carolina Tobacco Prevention and Control Branch. There are a few things to note about this policy that pertain to our recommendations. First, under Part 3A, the places in which the use of tobacco products are prohibited are listed as comprehensive categories. The second thing that we'd like to highlight is that under 4A, smoking and the use of e-cigarettes is prohibited in all enclosed areas of public places. Note, this is not a list of public places such as polling places, public restrooms, enclosed shopping malls, etc. This ensures that smoking and the use of e-cigarettes is categorically prohibited in all enclosed public places. These are just some of the important features of the model tobacco-free policy, but we think it's important to note that it's just that, it's just a model. Moving forward, Durham should use this policy as a guide, but also continue to be a leader in reducing tobacco use through innovative policy changes. So Jess.
Emma has provided you an overview of the county's smoking rule from its inception through its evolution of including e-cigarettes, as well as the current rate of tobacco usage in North Carolina, and also what a comprehensive tobacco-free policy is. And I will now walk you through some of the proposed changes we would like to make to Durham's policy. We have 3 goals that we would like to achieve when updating the smoking rule. The first goal is to ensure comprehensive coverage of the smoking rule to include all public places. In order to do that, we have 2 proposed changes. The first one is to clearly define public place within the smoking rule. As the rule stands, there is no definition of public place. And we would like to define it as it is defined in the general statute, which is an enclosed area in which the public is invited or permitted. The second thing we would like to do is to include public place as a category within the smoking rule. Currently, the categories in the smoking rule is just a piecemeal list of places that is prohibited to smoke, and that creates the risk of loopholes. And when we add public place as a category, that reduces and potentially eliminates those loopholes. Our second goal is to align the language with the model policy from the Tobacco Prevention and Control Branch. In order to do that, we would again revisit the categories in section 17.93 of the smoking rule and align them with the model policy that Emma has presented earlier in the presentation. So the categories will be 5 categories, which will include government buildings, vehicles, government grounds, public places, and then all other city and county property, which includes parks, buses, transportation systems, etc. And we will also make sure all those categories are clearly defined within the smoking rule. Our last goal is to create an enforcement mechanism. Currently, the enforcement tools in the policy is limited, and how we would like to change that is to offer tobacco cessation and education courses as an alternative to the civil fine. Currently in the smoking rule, there's a $50 civil fine, but that fine is not addressing the basis of tobacco usage, which is addiction. And so we would like to make that edit, as well as when those infractions occur, how we are handling those infractions. So who's going to be tracking them, who's going to be managing them, etc. So now we would like to share some next steps. We recognize that this is the first of many presentations to you all, but we have started some next steps and we would like to share those with you. First, we've established a county smoking rule review committee. The committee consists of Durham County staff as well as residents. The purpose of this committee is to provide technical expertise as well as lived experience as we work to update the smoking rule. Though committee members will be engaged through understanding the smoking rule, where it currently stands, where we would like for it to go, as also they will be engaged in tobacco education, tobacco-free policy initiatives, and community engagement efforts. We will be more than happy to share that progress as we continue, as we've just started working with them this past month. The second thing we are planning to do are community engagement and education activities. And we have one activity that we have outlined at the bottom, but our activities are going to be targeted towards those who the smoking rule affects, which is everybody in Durham County, but definitely some subpopulations within Durham, such as owners and operators of public places and the youth. So at the bottom of the PowerPoint of the slide, the example that we've provided is some of the activities we'll be doing in November, which is Smoking Cessation Month. And that includes a social media campaign to residents that will go over the current smoking rule and provide education about why smoking tobacco or using tobacco, the effects it has on their body, as well as the resources that the county has if they are ready to quit. Additionally, we will have weekly tabling in the county through community partners, as well as tabling within the Health and Human Services building. And lastly, we will hold a town hall for county residents to come and ask questions about the smoking rule and the proposed changes. At this time, we welcome any questions you may have.
First of all, thank you very much. This is, it's great work, very much needed, and appreciate the presentation. Just a couple of questions. First one is, are there other counties in the state of North Carolina that have similarly aligned language that would be comparable to what we're proposing as updated language?
Counties? No.
Okay.
Raleigh has just passed, in the past 3-4 months, on the city level, not the county level.
Okay.
So that is the example we can look at. But we are hoping that Durham will lead the way as the first county to do this.
Fantastic. The committee you mentioned, the Durham County Smoking Rule Review Committee, would you just be able to send us who's on that committee and how often that they meet, just so that we're aware of who's involved in those discussions? It seems like they're going to be pretty influential in the evolution of the policy itself.
That's not a problem. They are meeting on a monthly basis.
Okay.
We have not scheduled the second meeting for September, but we are also accepting members on a rolling basis as well.
Okay.
So I can send you the information of the people who are currently, as well as if you would like to pass out that information to other people who may be helpful. Yes.
So I love this, and I'd vote for it right now if I could. My team runs the statewide perinatal tobacco cessation program. So I'm offering whatever support I can offer. I mean, I'd love to go to the town hall, but anything I can do to support you, particularly on the maternal and infant health benefits, I am there, and I'll bring friends.
Okay. Thank you. Yes.
Wonderful presentation, Ms. Emma and Jasmine. Thank you so much. Wonderful research. This might be super nitpicky, but like, what is an enclosed area?
So an enclosed area, as you hear it as enclosed, I think something that's covered, but it's really anywhere that the public can walk into. So for example, I'm trying to think of what it's called. A park, but also I'm thinking like a social area, I can't remember the name of it, that has the shipping containers.
Oh, yeah.
Like box yard.
Box yard, yes, box yard. That is considered a public place.
It's defined by statute too.
Yeah, it's,
Public places or enclosed?
Both, actually. Enclosed area is an area with a roof or other overhead covering of any kind and walls or side coverings of any kind, regardless of the presence of openings for ingress and egress on all sides or on all sides but one.
thank you.
So again, just like I'm just curious, but like the farmers market, like you know, where it has like a roof, but it's outdoor, that's an enclosed area, so.
I
Well,
will defer to
Yeah. Well, cause I
overhead
personally
covering
would
of
want
any kind
anyone to be smoking
and
there.
walls or side coverings of any kind.
But there's not side coverings.
Yeah, so it's an outdoor,
Does have an overhead cover.
and think about the definition.
Yeah.
I mean, I personally don't want anyone smoking near the vendors and all that. So.
But I think you're hitting on something that I thought about this, which is there a contradiction between using the word enclosed and also including open air public spaces like sidewalks and transportation centers? Could it open this policy up to criticism because of a potential conflict of those two definitions?
I would suggest that before any final language is approved,
Yeah.
that the legal department thoroughly vet it.
Exactly. So that was what I was getting to, is there a process for a legal analysis and report of the proposed language?
Yes.
Okay.
I do want to say that we want to work with legal before any final language is voted on, so that is part of the plan.
And the ask of the board tonight is a vote on moving it to the next step, which is legal counsel, so, yeah.
So I'll entertain a motion, because I don't think it's probably under much debate. All in favor of moving this forward toward legal analysis and continuing the next steps that were recommended in the presentation? Or should, maybe, all in favor?
No, you want a motion in a second, don't you?
Yes, motion in a second.
I move.
Second.
There you go.
Okay, all in favor? Aye. All right, so you have unanimous, we very much support you. And I assume, how frequently should we, this is probably gonna be a very frequent topic of discussion. This should be like a standing item on? Okay.
Ms. Sturdivant and Ms. Llewellyn, thank you so much for this presentation. This is near and dear to my heart. As a primary care physician, I see lots of youth who are engaged in tobacco use, and one of the things that I hear from youth who are engaged in tobacco use is correlation between nicotine use and aiding with anxiety, right? And I was wondering if within this kind of focus group and community groups that you're kind of putting together, is there room for a behavioral health, specialist to kind of be a part of that, to kind of help guide those discussions about continued mental health improvements in the youth who may be turning to nicotine use to help with primary anxiety?
Definitely, and I'm gonna shamelessly plug this, but I have officially, the first one in North Carolina, a youth anti-vaping council for Region 5. And so I would love a behavioral health specialist to work with them, because they are going to be the voices of things like this, with enacting change within their counties within the region. So there's definitely space for them there and here.
Any other discussion, questions? Thank you all very much.
Thank you.
All right, some great presentations. Thank you all for your time and energy presenting that information to us. All right, next item on the agenda, we're going to move to board discussion. The first item, Dr. Jenkins, it's going to be the vacancy report.
Great, some unfortunate news, it continues to rise, but for some good reason. I will say, for the month ending in June 10th, it was at 10.4%. Month ending July 31st, 12.4%. Due to a number of different things. We did have some promotions, we did have a few dismissals, and many resignations, but I will say we also had some retirements. So the ebb and flow is kind of there, but we do feel as if we're in a better place. We want to get back to getting it down. I also continue to give praise to our leadership team who meet bi-weekly to discuss our vacancies and just ensure that we are tracking who's coming and who's going. So, yes.
Thank you. Any questions about that report, vacancy report?
How are you, sir?
All right, hope you are.
Every day. So with respect to the vacancies, are there currently any of those out being posted, advertised, in line up the large number of turnover?
I'm sorry, I didn't hear the question.
So are they being advertised? You said there was a lot of turnover.
Absolutely.
Are they currently posted and advertised?
Absolutely.
Okay, all right.
We advertise both internally, externally, and we use various sites to ensure that we advertise.
Do you have any concern? You said there were many.
None. We normally have a very good pool of candidates.
Okay.
And as a result, we're able to, as they say, pick the most qualified.
Thank you.
Any other questions? All right, we will move on to the NLB report.
Couple of things that we point out. You all noticed that the end of June ended the year for the compliant list, and so the July list only has 2 compliants on there. But one of those worth mentioning is 2607 Gear Street. You notice that they had a straight pipe, and a straight pipe is just what it says, that instead of going through a septic tank and a drain field, there's a straight pipe full of sewage going out somewhere, discharging into the ditch out there. It's full of sewage. Anyway, we got the owner of that property to start working with us, and we corrected the straight pipe, and then one of our staff went in and did a dye test, and that's just what it means. You put dye in the system, flush it down the toilet or something, and then you look for it out in the field, right? We didn't find it. So we were suspecting that that straight pipe was the source of the sewage. At least a portion of it now it probably was, but there's something else going on. So now we're continuing to investigate, look at adjacent properties. So that was a legacy NOV from back in '24. So we were glad to get that off, and now we got more work to do to try to figure out where this is coming from. I would like to point out too that it's a little related, or it's water related. The drought and the heat hides a lot of NOVs, right? It's good for that, but they could come back in the wintertime. Durham is still under stage 2 water restrictions, whereas Raleigh lifted it last week. But we're dry again. There's no rain in August, and they're already reporting that falls is beginning to drop again. So we're not out of the woods when it comes to water yet.
Thank you very much. Any questions about the NOV report? All right, last item on the agenda, Dr. Jenkins, back to you, the health director's report.
Thank you, Mr. Chair. I always pause because there's so much good inside this health director's report. It becomes tough to really select 3 things to talk about, but I'll trudge on. I'd like to lift up our valiant preparedness coordinator, Mr. Corey Morris, under the tutelage and leadership of Mr. Chris Salter. We achieved what we call Project Public Health Ready status, which is national recognition, and it's criteria based upon program developed by the National Association of Counties, County City Health Officials, NACCHO, and the CDC. That was publicized widely throughout the county, and it is no easy feat. There's a lot of work that went into it, from preparing preparedness plans to doing everything associated with checklists and annexes. But we did that, and it's going to help us with public health national accreditation. So wanted to lift that up and express my gratitude to Corey Morris and Chris Salter, because again, a lot of work went into that, and that's a very, very good designation to have. And then I moved to population health under the leadership of Mrs. Marissa Mortimer. We have a very dynamic health and history project that's going on, That is a collaboration between us and the Southern Alliance for Public Health. And we partnered with North Carolina Institute of Public Health to create 30-minute learning modules for our Decode public health staff. My leadership team reviewed it on Monday, and we are preparing to roll it out. And we do believe that it's going to help us to be better practitioners, better public health professionals, because it teaches us about the history of Durham and why things are the way they are right now. So when that individual comes before us seeking help, we can know what area of Durham they're from and know the history behind it. So again, just really shout out to Marissa Motorboy. She has done a fantastic job in designing it. And I will say, even with special shout out to our legal counsel, Kristen Lott, even with the DEI stuff going on, we still thought it not wrong to check in just to make sure that this is something that we can do. And it has everything to do with data and health. So we got the green light on that. So we certainly want to make sure that we're thankful for it. Last but not least, as mentioned previously, our dying team continues to do wonderful things. Big shout out to Kelly Warnock. I don't know if she's here, whether she's left or not, but she had to leave. But we do have a lot going on with Everyone Eats Durham. And again, it's a collaboration of 15 food pantries and hunger relief organizations. It's all about increasing awareness of food insecurity in Durham. They have an ambitious goal of raising $500,000 by July of next year, and I think that they will do it. But most importantly, there is going to be a huge celebration the week of September 12th to 20th, but during Labor Day, we will have a sort of confluence and collaboration between the Blue Cross Blue Shield Foundation and Durham Bulls, in which they will host a Labor Day food drive. I believe entry is going to be some canned goods or whatever have you. And then we're also going to have a Durham County official, not necessarily named Stephen Valentine, but we're going to have a Durham County official to throw out the first pitch. So,
Are you practicing?
I think he's up for it. But I think it's going to be like one of his colleagues. I have to say.
Okay.
That concludes my review.
Well,
Happy to
that's
answer any questions.
Can we get access to that training?
Yes. I've already had a note to send Board of Health members the health history training.
Yeah.
So more than happy.
I would like to see that.
I
great.
I really feel you're going to enjoy it. Really well done.
Fantastic. I was excited to see that Labor Day Durham Bulls connection. Hopefully there's going to be some proactive marketing and things to promote the department's involvement in that part.
Sure.
All right, fantastic. Any questions about the health director's report? All right, continued great work by the department. Really appreciate it. All right, doesn't look like there's anything needed for the committee reports. There's nothing under old business, so we'll move right on to new business. We have 1 budget ratification and 4 budget amendments. So Dr. Jenkins, you want to talk about, can we do all those at once?
We can, and I'll start off with the ratification. Board is requested to approve budget ordinance amendment to recognize funds in the amount of $2,444 from the North Carolina Department of Health and Human Services Division of Public Health under the Epidemiology section, CD branch. These funds are to provide routine HIV/STI screening, treatment, and prevention services through their sexually transmitted infections and family planning clinics at no cost to the client. That is the ratification. Moving to the amendments, the board is requested to recognize $392,926 from the North Carolina Department of Health and Human Services Division of Public Health's Local and Community Support Section for Local Workforce Development. These funds will be a part of an effort to recruit and retain highly qualified staff. These funds will also support foundational services and core functions of the Durham County Department of Public Health. Next is the board is requested to recognize $15,000 from the North Carolina Department of Public Health for the Improving Community Outcomes for Maternal and Child Health Grant, ICO for MCH, for Family Matters Durham. They are doing wonderful work, and this funding represents an increase in NCDHHS funding for ICO for MCH initiatives. Next one is the board is requested to approve $56,250 from the North Carolina Department of Public Health, Chronic Disease and Injury, Tobacco Prevention and Control Branch to support evidence-based tobacco, nicotine prevention, and succession training in Region 5. That is all Jasmine Sturdivant, and as you have witnessed, she is off and running. So we appreciate your support with that. Last but not least, the board is requested to approve submission of a letter to the North Carolina Department of Health and Human Services outlining the aggregate percentage change of 1.42% in public health's charge master rate. For managed care Medicaid claims activity, public health does receive a quarterly separated direct payments. The separate directed payment calculation is based on public health specific ratio of cost to charges as determined from the base year, state fiscal year 2019, Medicaid cost report, and trended forward annually for inflation. The rate is annually adjusted if the aggregate price changes or the charge master change are more or less than allowed for inflationary increases. That is it, Mr. Chair.
That's a mouthful. I commend you. Just a quick question about the charge master changes. That's effectively to keep up with maximum reimbursement allowed by the policy. It's basically we're increasing our charge master rates to keep up with, make sure we achieve the maximum available reimbursement for those managed Medicaid claims.
And this is our opportunity to tell Medicaid that we have changed our fees, but it's retroactive, so
Okay.
that 1.42% based on the changes that we made from fiscal year 23-24 to 25-26. Now they ask us about 25-26 to implement moving forward.
Okay.
Most of those changes, this is higher than it's been in the last couple of years, and most of them are related to fees associated with administration of vaccines, and also a new code that came out. There's only a certain allowable code that they take into account, and it also has to do with the number of times we perform that procedure. It's a fairly complicated thing, but they send us very clear directions and we kind of input the data and then send it back to them.
Great.
I move that we adopt all of these.
Second.
All right, we have a motion and a second. All in favor of adopting the ratification and the 4 amendments?
And the budget ratification?
All of it.
Yes, all of it.
Yeah.
Aye. All right, that is approved. Next item, agenda items for next meeting, which would be in October. I think we already discussed the smoking rule, we'll stay there. Any other items that we want to discuss?
I would like to talk more about the changes in case management service provision.
Okay.
Yeah.
We did have that, Dr. Davis, update on care management. That is our CMARC care management for high-risk, at-risk children, and SIMHARC care management for high-risk pregnancies. We'd love to give you an update and hopefully our plan of action.
Okay.
And also, I do believe that we probably will provide an update on, no, we'll save that for in person.
All right.
You got Mr.
So the next one is online, right?
Now, if I recall, we do trainings usually in December,
Yes.
but that would be in person. Is that still feasible, or should we move training up?
Very reasonable.
It's very feasible?
Yeah.
Okay. All right, fantastic. One thing, just because I rode my bike through there this weekend, is there a possibility of just a brief update on the lead in City Park situation? See if there's been anything that's changed. Yeah, just a brief.
I can give you a brief right now if you want to.
Sure.
I haven't been able to look at all the reports that have come out, but the final reports have come back from DEQ, and the city is actually reaching out to, I think they're looking at vendors to evaluate and give them more guidance on how to move forward. So that's where they are right now.
Great. All right, anything else? Go ahead.
super informal, but just top of mind. Like with the lettuce contamination, were there any concerns with Durham Public Schools cafeterias?
We have had conversations with Durham Public Schools officials about it, and we have indicated that there was no concerns. For the most part, I want to say several assistant superintendents, when it was really in the headlines, had reached out and just said there was none at the time.
Thank you.
All right, we've got a good number of agenda items. Just continuing, any more informal discussion? I'm gonna say this out loud. I'm assuming that this week's executive order around vaccination recommendations will have no impact on any policies?
That is accurate. We received from the head of DPH, Dr. Kelly Kemple. Again, I still serve as a as a past president for the Association of Local Health Directors. And on yesterday, she indicated that there are no concerns with the state.
Okay.
Can I just, if anyone is not already getting your local epidemiologist, it's a email that is put out at the national level by people who are epidemiologists who look at what's happening around the country on all of these issues. And they just did an email on what do the new changes actually mean, and they said basically nothing. But it's a really great newsletter, and it's free, and it's just called Your Local Epidemiologist. So I highly recommend it.
So I am subscribed.
Yeah, it's a great.
And I'm assuming we're gonna track to see about any impact of that in our county, right?
Absolutely.
Yeah.
Great. Any other informal discussion? All right, well, unless there's any disagreement, we'll take a motion to adjourn.
So moved.
Second.
It's moved and seconded. All in favor of adjourning the meeting?
Aye.
Awesome. Thank you, everyone. Thank you for being here. Thank you for the presentation. Really appreciate it.
Great.